In here. Yeah, but paper number 11 will be moving to 10. So we're 5 minutes. So you're going to reset it at each time. You usually have to do it on my phone. Nicer. All right, if everyone could take a seat, we will get started in 1 minute with the scientific session. All right, it's the top of the hour, so we will get started. So welcome everyone to Parallel Plenary Session 3. If that's not where you're supposed to be, you can gracefully exit. We are happy to have all of you here. I'm Amy Hildreth. I'm an acute care surgeon at Wake Forest in Winston-Salem, North Carolina.
I am Lexi Solt. I am an acute care surgeon as well at Eastern Virginia Medical School in Norfolk, Virginia.
And we will be doing short orals, which will be 5-minute presentations. For the presenters, there is a timer down front in case you need that visual reminder. And then we'll have 2 minutes of open Q&A, and we will not have an assigned discussant for these papers. So we'll go ahead and begin. The first paper is presented by Dr. Abdel Aziz, and they're from the John H. Stroger Jr. Hospital of Cook County. And the paper is "The American Association for the Surgery of Trauma Organ Injury Scale for Spleen does not equally predict interventions in penetrating and blunt trauma."
Good afternoon, everyone.
Press the button right. Yes.
Okay.
And brings forward, then back.
Good afternoon, everyone. My name is Hussam Abdelaziz from Cook County Health in Chicago. Today, I would like to talk about that the mechanism of injury is as important as the grading of injury when it comes to the management of spleen trauma. I have no disclosures. So it has been no major change in the grading, the AAST grading for the last 30 years. And as we see here, the grading for the spleen, that we can see that in the first 3 grades, there was only changes in the subcapsular hematoma, and only for grade 4 and 5, there was increase in devascularization injury. So there was a validation study done and published in the American College of Journal of Surgeons. There was over 20,000 patients included in this study, but there was almost all the patient was plantar trauma, 93%. So we did a retrospective review study from the TQIP database for 3 years. And from 2017 to 2019, we included all the patients with abbreviated injury scores that have spleen injuries. Also, we use the ICD codes for procedures like embolization and splenectomy. We identified over 60,000 patients with spleen injuries. And as we see here, that the embolization rate is driven by the grade of injury, but it's not the same thing for penetrating injuries. So that means that the mechanism of injury is such as important as the grading of injury. In operative management, we can see that the spleen-specific operations and the splenectomy rate is increasing for the blue blunt trauma in every grade. But in penetrating injury, it's increasing in low grades, but there was no significant difference in high grades, especially in grade 4 and 5. Once again, that means that the mechanism of injury is important as the grading of injury. So my conclusion is the AAST organ injury scale does not equally predict the interventions in splenic injuries, which mean that we have penetrating injuries that require more surgeries and splenectomy, and also implant injury can be managed by embolization. So surgeons should consider the mechanism of injury when it comes to management of splenic trauma injuries, and while you're using the AAST organ injury scale. Thank you, everyone.
All right, we'll take questions from the floor.
I can start and open our discussion here. Thank you so much, Dr. Aziz. In evaluating your patient population of these splenic injuries, do you think that there's some bias that happens with the penetrating splenic injuries that you're more likely going to be operating on them in the first place?
So we did analysis like we didn't include all the patients together. We just separated the penetrating injuries and separated the blunt.
Like the organ injury scale had not really changed, but actually in 2018, they issued an update where vascular injuries, right, where they're identified by a pseudoaneurysm, blush, and whether or not that extended outside of the splenic capsule or not, automatically became a grade 4 or 5. So whereas you may have a smaller laceration, if there's contrast blush, it automatically becomes a grade 4 if it's confined within the spleen, or a grade 5 if it extends beyond that. My question is, I wonder whether or not that would account for why you see such a higher rate of operative intervention, that while these were initially graded as a lower grade prior to the 2018 update, that you might see those now as a more high grade, and that perhaps I think often what we see with these things is that surgeons gestalt for who needs an operation tends to go beyond just what we see with our organ injury scale. And just wondered if you could comment on if that was possible.
So like about the penetrating injuries?
Yeah, with penetrating injuries, whether or not you tended to see more frequent vascular injuries and whether or not those extended into the peritoneum, since that's typically how the projectile object, whatever, would have entered the spleen.
So about penetrating injuries, we didn't know like what type of injuries we have. Like we just like made all the patient like have penetrating injury, and we concluded our data about what interventions we will do toward them. Like, so in high grades 4 and 5, we like most of the patient required interventions, operative interventions, but there was no difference because there was no difference between grade 4 and 5. That's what we found, but we concluded all the patient according the interventions, but we didn't include about the vascular injuries.
All right, thank you very much.
Thank you.
Our next presentation is postoperative outcomes following major lower extremity amputations are dependent on surgical service line and patient frailty. This is being presented by Dr. Allison Kurowski and is from the University of Maryland.
And if we can have presenters come to the front of the room right prior to your paper.
Thank you very much. I'm not a doctor yet. Hi, everyone. I'm Allison Karwoski. I'm a second year, soon to be third year medical student at the University of Maryland. I'm really excited to be discussing my project on postoperative outcomes following major lower extremity amputations are dependent on surgical service line and patient frailty. Right here. All right, I have no disclosures. So major amputation is a commonly performed procedure. About 150,000 patients a year undergo a lower extremity amputation in the United States. The most common causes leading to amputation are diabetes, peripheral vascular disease, neuropathy, and trauma. Indications for amputation are related to the degree of tissue necrosis or viability, and it is performable in either a single operation or a staged manner, amputation followed by a reconstruction. The decision to take on either approach depends largely on the clinical status of the patient and the quality of the soft tissues at the desired level of amputation, with the primary goal of being able to excise the non-viable and infected tissue. An underlying goal in the care of the patient who requires amputation is to retain the knee joint if possible, given its contribution to more efficient ambulation with a prosthesis and less energy expenditure. Here are just some of the complications that can arise from major lower extremity amputations, and those include cardiac complications, wound infection, phantom pain, pneumonia, and subsequent reoperation. Access to quality emergent and urgent surgical subspecialty treatment has been a challenge for many hospitals in the United States to provide due to lack of availability or shortage of surgical specialists. Hip, knee, and foot injuries are among the most common reasons for presentations to the emergency department. To find adequate coverage for lower extremity call, hospital systems often draw upon orthopedic, vascular, and trauma surgeons with different training backgrounds to provide lower extremity amputations. Training background has been shown to impact outcomes for specific procedures, such as vascular versus general surgeons for abdominal aortic aneurysms. So the aim of our study was to explore and compare surgical outcomes following major lower extremity amputations between vascular, orthopedic, and trauma surgeons at an academic tertiary center. We specifically wanted to determine if primary surgical service performing the major lower extremity amputations affected reamputation rates, ambulation status, and mortality-based outcomes. So we conducted a retrospective chart review of University of Maryland Medical Center EPIC records and included patients who underwent a major amputation between 2015 and 2021. Patients had to be greater than 18 years of age and have comprehensive pre, peri, and postoperative outcomes. Our sample includes around 750 patients and 464 were reviewed for interim analysis. In our chart review, we collected data on patient factors and comorbid conditions, perioperative factors, including amputation location, the level, indication for amputation, and operative time. We also included complications, follow-up notes, survival, reamputation, and whether the patient ambulated with a prosthesis post-op. We split up our patients and categorized them into patients who are frail and non-frail patients using the 5-factor modified frailty index. This was to control for frailty in our patient population. We did a statistical analysis of the data using a bivariate chi-squared analysis for our 2 patient groups, so frail versus non-frail. Of the 464 patients analyzed, the mean age was 58.9. 78% of patients in our sample were categorized as non-frail based on the 5-factor modified frailty index, with 22% of patients frail. So vascular surgeons performed 219 cases, that's 51.4%. Orthopedic surgeons performed 75 cases, and trauma surgeons performed 132 cases. Open or guillotine amputations were performed by all services evaluated. There were 361 non-frail patients in this cohort. Within the non-frail group, 68% of trauma surgery patients got re-amputated in 30 days, followed by 61% of orthopedic surgery patients and 58.7% of vascular surgery patients with a p-value of less than 0.001. Orthopedic surgery had the highest rates of patients who achieved post-operative ambulation with a prosthesis, followed by vascular surgery and trauma surgery. There were no differences between surgical specialties in 30-day and 1-year mortality and 1-year reamputation in the non-frail patient population. We had 103 patients in the frail patient cohort. We found no differences between surgical specialties in 30-day and 1-year mortality, 30-day and 1-year reamputation, and post-operative ambulation with a prosthesis. So in conclusion, in non-frail patients, the surgical specialty performing the lower extremity amputation had an effect on postoperative outcomes. In frail patients, postoperative outcomes were dependent on comorbid conditions more so than surgical service. I'd like to thank my mentor and PI, Dr. Nagersheth, and for his support and mentorship, and as well as my colleagues, my references. Thank you. Happy to answer any questions.
We will now open the floor for discussion.
I have a quick one while folks are coming to the microphones. Did you, in the non-frail patients, did you look at indications for amputation? I just have a suspicion that I still have a suspicion that the indication for amputation might matter more than the actual surgeon doing it. Can you elaborate on that a little bit?
Yeah, so we did later on include indication. We're actually we've completed the data set. We're going to actually look at that now. And that'll be the next round of reanalysis when we write the manuscript. But yes, we did.
Okay, thank you. All right, thank you very much.
Thank you.
All right, our next presentation is by Dr. Beeson from New Hanover Regional Medical Center. Small aim, small miss, taking small bites improves consistency in fascial closure simulation.
Hi, thank you. My name is Seth Beeson. I'm a general surgery resident in New Hanover in Wilmington, North Carolina. And I'd like to thank the Congress for allowing us to present our research. We do not have any disclosures. So with millions of laparotomies performed every year, incisional hernia continues to toll a huge burden on the healthcare system. And with hernia rates as high as 30% at 10 years from the index operation, there's obviously well-known patient-related risk factors for hernia development. And in 2015, the European Hernia Society released some guidelines to their surgeon-related factors that can help mitigate these risks for hernia occurrence. And the one of these that's the most discussed is utilizing a 4-to-1 suture to wound length ratio by taking small bites and small advance. And we started thinking about that and why is it that technique works to decrease hernia rate. The simple physics of it makes a lot of sense. By utilizing more suture, you're overall decreasing the amount of stress on the entire wound. Also from a biologic standpoint, by taking smaller bites, you're incorporating just the fascia in the closure, resulting in less tissue ischemia and necrosis. And then one thing that we looked at with our research is by taking a smaller bite and smaller travel, are you actually improving your technique and utilizing more consistent, accurate bites? Because it really only takes one large bite or one miss to create a nidus for hernia formation. So our research questions were, in a simulated setting, does utilizing a small bite technique improve accuracy and precision of the bites, as well as utilizing a templated closure result in better accuracy and precision of bites? So we had 14 residents participate in the simulation. A 10-centimeter incision was made in a felt model that we've used previously for fascial closure simulations. And then each resident performed the closure 4 times. For the first 2 closures, they were instructed to take a 1 centimeter bite with a 1 centimeter travel. And in the second closure, a 5 millimeter bite with a 5 millimeter travel. And then the second 2, that process was repeated, but with a templated closure. So here's a kind of a visual representation of the simulation. It's got a box with an open middle. And then the middle picture is one resident's attempt at a 1 centimeter bite without any template. The picture on the right is a 5 millimeter bite with a templated. You can kind of see if you're up closer, the dots of the template on the felt. So, and then each closure was timed, and what we found was expectedly by taking more bites with a 5 millimeter closure, that did take significantly longer. And then interestingly, when comparing the templated to untemplated groups, though not statistically significant, it did err towards significance that utilizing a template was a little bit faster. Then to test accuracy, we used 1 centimeter and 5 millimeter bites as the gold standard and compared each bite for the distance away from that. And what you can see is that when taking a 5 millimeter bite, on average, residents are getting inside of 1 millimeter to that gold standard compared to utilizing a 1 centimeter technique. Both the standard deviation and the raw value is significantly greater. So residents were 2.5 millimeters off in their accuracy. Then to test precision, we found each resident's average length and then compared the bites to the average size. And what we found was that on the right side, meaning the forehand, when you're taking your first bite into the fascia, when compared templated to untemplated, utilizing a template improves standard deviation and improves bite size consistency, as well as when you use a 5 millimeter bite compared to 1 centimeter bite, your standard deviation and consistency is also better. Interestingly enough, that was somewhat held true when on the left side, when you're taking your forehand bite up and out of the fascia. However, there was not statistical significance there. And then when comparing the travel width, that was echoed as what we found on the right side, is that residents were both more accurate and more consistent when they with their travel as well. So discussion points, you can improve your bite size technique by either taking small bites and small travel, or utilizing a template. And that small bite technique does take longer. Obviously, one drawback: this was all performed in a simulated setting, and transition to practice is questionable feasibility, particularly with utilizing a template in a real fascial closure would be difficult. And then we need to continue to measure suture to wing length ratio and hold ourselves accountable as surgeons to take good technique. And then some future research, we're going to try to perform this longitudinally and see if pure experience, by comparing a resident in their 4th year to their intern year, if pure experience gives you better technique, as potentially could be one other factor. And thank you for your time, and take questions.
All right, we'll take questions from the floor.
I can start by asking, so as far as this goes, this is wonderful as your practice, and applying it to clinical world will be the next step, as you mentioned. Do you think, based off the time that you've been doing this, just the more discussion with all of the residents, and then looking at are they implementing it further within their practice?
Yeah, we actually had done a previous study where we kind of somewhat developed this felt model, where we just, for 100 patients, measured baseline ability to our success rate of achieving a 4-to-1 ratio. And what we found was, at that time, a independent risk factor for achieving a less than 4-to-1 ratio was when 2 residents performed the closure without the supervision of an attending. And so then we did a simulated model like this, did a resident journal club, and then followed 100 patients afterwards, and found that we were able to improve that to a 90%. So I think simply education and utilizing simulation and making people aware that using a small bite technique definitely improves implementation.
Just a question about your comment about templates and their the ability to use them in clinical practice. Is there another way that you could provide a visual reminder of some sort, or distance measure for those who are less their spatial perception allows them less to figure out exactly what 5 millimeters is?
Yeah, I mean, potentially having just a ruler by the incision, or I mean, we're trying to think about of ways to actually incorporate a template, because you can't leave a foreign body in the fascial closure. So that certainly creates challenges. But yeah, I mean, either having a ruler or potentially marking on the skin or drapes what a 5 centimeter or 1 centimeter by prior to the closure may help.
All right, thank you very much.
Our next presentation is Contemporary Treatment Paradigms, Increased Survival in Pancreatic Cancer. This is being presented by Ms. Bridget Kelly, and she's from Maine Medical Center.
Good morning. My name is Bridget Kelly. I'm a second-year medical student. I wanted to say thank you to SESC for allowing us the opportunity to present the results of our study, Contemporary Treatment Paradigms, Improve Survival in Pancreatic Cancer. I have no disclosures. Prior to 2011, single-agent chemotherapies such as fluorouracil and gemcitabine were used as the mainstay of systemic treatment for pancreatic cancer. In 2011, Conroy et al. Published the results of a prospective randomized clinical trial demonstrating improved overall and progression-free survival with FOLFIRINOX, a multi-agent chemotherapy regimen over gemcitabine alone for patients with metastatic pancreatic adenocarcinoma. Soon after, in 2013, Von Hoff and colleagues demonstrated improved overall survival with the multi-agent chemotherapy regimen, gemcitabine and nab-paclitaxel, over gemcitabine alone in patients with metastatic pancreatic adenocarcinoma. Additional studies in the following years showed improved resectability with neoadjuvant multi-agent chemotherapy. These studies marked a paradigm shift towards the use of multi-agent chemotherapy for patients with pancreatic cancer. While large studies published in high-quality journals often generate considerable conversation about their potential effects on particular patients, their impact on clinical practice at the population level remains unclear. We sought to compare outcomes of patients treated prior to the publication of the initial multi-agent chemotherapy trials to those treated after. We hypothesized that the survival advantages of multi-agent chemotherapy for patients with pancreatic cancer would be reflected as improved survival and increased surgery rates at the population level for patients with pancreatic cancer at all stages of clinical disease. Our primary outcomes of interest were multi-agent chemotherapy use, surgery rates, and survival. We conducted a retrospective study using data obtained from the National Cancer Database. Patients diagnosed with pancreatic adenocarcinoma from 2006 through 2019 were identified. These patients were designated as ERA 1 if they were diagnosed between 2006 and 2010 prior to the publication of the initial multi-agent chemotherapy trials, or as ERA 2 if they were diagnosed between 2011 and 2019 following the publication of these trials. Rates of multi-agent chemotherapy per year are seen in the top figure. From ERA 1, we had a mean multi-agent chemotherapy use of 22%, which increased to 44% in ERA 2. The bottom figure shows median survival per year. Again, we see an increase in ERA 2 with ERA 1 median survival of 6.3 months and median survival in ERA 2 of 7.8 months. To assess whether these increased survival seen that we saw across the entire cohort from ERA 1 to ERA 2 persisted also in our surgical patients as well as across different clinical stages of disease, we conducted a multivariate survival analysis, which included age, race, insurance, income, facility type and location, Charles-Deo score, population type, and tumor grade. This analysis demonstrated a survival advantage for surgical patients in ERA 2 over ERA 1. Patients were designated as imminently resectable if they had stage 1A or 1B disease, high risk if they had 2A, 2B, or 3 disease, and then stage 4. This survival analysis also demonstrated improved survival in ERA 2 over ERA 1 across all clinical stages of disease. However, we did see that surgery rates decreased from 20.5% in ERA 1 to 19.8% in ERA 2, which was surprising given that previous studies had shown increased resectability with the neoadjuvant use of multi-agent chemotherapy. In this subset analysis of surgical patients, we saw that median survival improved from ERA 1 with 18.7 months to 24.6 months in ERA 2. When these surgical patients were examined by chemotherapy, we saw that surgical patients that did not receive chemotherapy had a median survival of 17.6 months compared to those surgical patients who received multi-agent chemotherapy had a median survival of 27.4 months. When broken down by stage of diagnosis, eminently resectable patients who underwent surgery had a median survival of 25.6 months compared to those eminently resectable patients who did not have surgery with a median survival of 7.8 months. When looking at the high-risk patients, surgical patients had 21.1 months of median survival compared to 8.7 in those who did not receive surgery. In conclusion, an NCDB analysis of patients with pancreatic adenocarcinoma showed a rise in the rates of multi-agent chemotherapy use. Following the publication of these clinical trials in the early 2010s, which is reflective of a shift in clinical practice on the population level. In regards to the role of surgery, we saw an increase in median survival in surgical patients with eminently resectable or high-risk clinical stage disease following the publication of the trials. Unfortunately, surgery remains an underutilized tool for the treatment of pancreatic adenocarcinoma. I'd like to thank my co-authors, and I'm happy to answer any questions this time.
You all open the floor for discussion, please.
Hi, how are you? Great presentation. Seth Rosen from Memory. Really congratulate you on your work and your presentation. Great job. So one question I have is that's about a 15-year period. I believe there have been significant advances in imaging, the quality of imaging, and using imaging to select people for surgery during that time period. Was that part of your analysis, and did that play any role in who was offered surgery? Thank you.
Great question. Thank you. So because this was a national cancer database study, we were unable to look at details like that. However, I think this really brings up the question of sites being able to look at their own institutions and looking at rates of surgery and use of multi-agent chemotherapy at their own institution and opening up that conversation. So while I think that probably played a role in what we saw in our results, we're not able to look at that with our data. Thank you.
That was a really fantastic presentation and enlightening. Manny Zervos from East Carolina University, one of your mentors, former partners. I have a question for you, and I don't know if you can determine the answer from the NCDB or not. The first one is the eminently resectable patients that didn't undergo surgery. Is there any information that you can get from the database as to why they didn't undergo surgery, like number of comorbidities versus those that underwent surgery? And the second one is there any information that you can glean from the database of the sequencing of chemotherapy, whether it was given in a neoadjuvant or adjuvant setting?
Great, thank you for your questions. For the eminently resectable patients, I think that's a great question of why they didn't undergo surgery. It's not something that we looked at in particular, but I think that's definitely where future studies could go. And I think I would say the same thing for your second question as well. We did not look at whether the chemotherapy was administered neoadjuvantly or adjuvantly, but I think it's something that we can look at on the national level as well as the institution level.
Thank you so much.
Thank you also to Ms. Kelly from coming all the way from Maine to Georgia, basically the length of the Appalachian Trail to present here today. All right, we will move on. The next paper will be presented by Dr. Williams. Pediatric appendicitis transfers from adult centers. Can Alvarado scores help determine which patients need a CT? Green is forward. You might need to move the mic.
All right, my name is Jen Williams. I'm a PGY3 general surgery resident from Cooper University Hospital in Camden, New Jersey, and I'll be presenting our study, Pediatric Appendicitis Transfers from Adult Centers. Can Alvarado scores help determine which patients need a CT? We have no financial disclosures. Appendicitis is one of the most common causes of acute abdominal pain in adults and children. It has a lifetime risk of 8.6% in males and 6.7% in females. In the adult population, CT is the standard of care for diagnosing appendicitis. However, this is not the case for pediatrics. As the use of CT has increased over the last 30 years, it's become more common for adult centers to scan children at similar rates as adults. However, CT exposes patients to ionizing radiation, which may be particularly harmful to children. Several studies have observed a relationship between even low-dose radiation and CT scans and long-term health implications, including leukemias, brain tumors, and other cancers. We hypothesize that by using the Alvarado score to clinically stratify patients, that we can identify patient groups that can be transferred without imaging. We gathered data by reviewing the transfer logs and including all pediatric patients that were transferred with abdominal pain and concern for appendicitis from November 2020 to March 2022. We had a total of 196 patients included, and we used the Alvarado score, which has been shown in previous papers to use clinical findings to predict the likelihood of appendicitis. It has 8 components in which each get 1 point, except right lower quadrant tenderness and leukocytosis, which each get 2 points. And we collected all components of the Alvarado score seen here, as well as operative reports, pathology reports, length of stay, and demographic information. We then grouped patients by Alvarado score, with low score as those with a total of 0 to 3, intermediate is 4 to 6, and high is 7 to 10. The average age of the patients was 11 years old, and 58% were male. 131 of the 196 patients underwent CT scan, and approximately 2/3 of each Alvarado score group, low, intermediate, and high, underwent CT scanning for appendicitis. This graph demonstrates the rate of appendicitis by Alvarado score groups. On the y-axis, we have the number of patients. On the x-axis is the group of Alvarado scores, low, intermediate, and high. Orange represents patients with appendicitis, and blue represents those without appendicitis. In the low score group, the rate of appendicitis was only 14%. In the intermediate group, the rate of appendicitis was 62%, and in the high score group, the rate of appendicitis was 92%. This graph shows the CT imaging done separated by Alvarado scores. Again, on the y-axis is the number of patients. On the x-axis is each group of Alvarado score, low, intermediate, and high. Blue represents the number of CT scans completed. Orange represents the number of those CT scans with a positive read for appendicitis. And gray represents confirmed appendicitis by either perforation seen on CT or by pathology after appendectomy. In the low score group, 25 patients underwent CT, with only 6 patients that had a positive CT read. Of those patients, only 2 actually had appendicitis. The positivity rate of CTs were low in that group, and the positive predictive value of CT was only 33%. In the intermediate group, the positive predictive value of CT was 88%, and in the high group, the positive predictive value of CT was 98%. And you can see that with the gray bar showing true appendicitis approaching the orange bar showing positive reads on CT in the right column. In conclusion, CT scans are not equally useful across Alvarado score groups when evaluating for pediatric appendicitis. Low Alvarado score patients have a low likelihood of appendicitis, and CT has a low positive predictive value, so should be ordered selectively. High Alvarado score patients have a high likelihood of appendicitis, over 90%, making CT an unnecessary confirmatory test, which should be reserved for after clinical evaluation by the tertiary center. In summary, stratifying patients by Alvarado scores can reduce radiation exposure by CT scans. Thank you for the opportunity to present. Happy to take any questions.
All right, we'll take any questions from the floor. I'm curious, it seems that you tackling the CT protocols at your tertiary care center, that's probably the easy part of this equation. So how do you handle advising referring centers on the likelihood of a CT scan being helpful in your diagnosis, especially with our more mobile workforce in the post-COVID era?
Thank you for that question. I think that it's true. This is the easy start, is gathering the data and seeing what we can find from it. And I think publishing and talking about this and discussing it with our referral centers and just creating better open communication for that we'll accept a transfer without CT scans, because I think that's a large fear. And just understanding their role, if it's determining their disposition or not, and if they would rather transfer and we would observe the patients and go from there. So I think a lot of it's just gathering data and having open communication.
One more question. Do you use the Alvarado score within the tertiary referral
needing a CT scan for clinical determination, and if they are primarily in that intermediate group. And then if there's any change in outcomes.
All right. Thank you very much.
Thank you.
Next is the statewide analysis of predictors of trauma center transfers, the burden of non-clinical factors. This is being presented by Dr. Joshua Aldridge from East Carolina University Brody School of Medicine.
Good morning. Thanks for having me here. I'm a fifth-year resident at East Carolina University. Thank you for the opportunity to share our work from the trauma division at ECU Health Medical Center. I'll be discussing our project, as she said, about non-clinical factors in trauma transfers. We have no disclosures. So the ACS Committee on Trauma has developed and provided a model for trauma systems in regards to transferring patients that focuses on the rapid triage of patients with transfer to a higher level of care as needed. There's an emphasis in this model that focuses on avoiding under triage of patients and accepts a certain amount of subsequent over triage rate. The indications for transfer are variable and can be wide ranging. That includes the severity of injury, the need for ICU care, subspecialist or simply hospital bed need. And finally, trauma system protocols and patient preferences can also impact the transfer decisions. There's a perception amongst providers that non-clinical factors have become increasingly considered in transferring patients. And that over triage of these patients can overwhelm and burden the resources of a trauma system. Furthermore, these transfers not only displace patients from their local community and where their family and support systems are, but can also be very costly for both the patient and the trauma system as a whole. Previous research has demonstrated that insurance status and race are independent predictors of patient transfer and trauma. And unfortunately, there's an evidence that once transferred, many of these patients don't actually receive any sort of intervention from the specialist that they were transferred to see. And as many as 16% of orthopedic trauma transfers and 66% of hand transfers received no intervention and were deemed inappropriate by the referring center once they were arrived in single center series. So our study aimed to identify the non-clinical factors associated with the transfer of injured patients to the trauma centers in North Carolina. We performed a retrospective cohort study utilizing the 2018 North Carolina State Inpatient Database. We identified adult patients that was over the age of 18 with a primary diagnosis for transfer of spine fracture, rib fractures, extremity fractures, or traumatic brain injury. We specifically chose these patients because we anticipated that these injuries could be managed at a community hospital in an appropriately injured patient. So given the right patient and the right hospital, that these could be managed there. And they were divided into cohorts of retained at the community center or transferred to the tertiary care center. There were more patients that were actually retained than transferred in our results, with the retained cohort averaging nearly 10 years older than the transferred cohort. The injury severity scores were calculated for each group based on ICD-10 codes, with the transferred cohort having a mean score of 2.2 and the transferred cohort a mean of 2.9. This data is in line with what we would expect of mature trauma systems with transferring the more severely injured patients, but we'll take a look at this data through some different lenses. So this table demonstrates the breakdown of each cohort by race. And there was a significant difference in the racial makeup of the transferred and retained cohort, with a significantly higher minority population that was transferred. Similarly, the distribution of payer source between the two groups was unequal, with a higher proportion of Medicaid and self-pay patients in the transferred cohort than the retained cohort. Now, we also looked at the effective day and time on transfer. Transferred patients were more likely to be admitted on the weekend and overnight compared with the retained group. And for each primary diagnosis, these trends remain significant. So the difference in payer source persisted across all four different diagnoses. We also noticed that in all four diagnoses, nights and weekends were significant for likelihood of transfer. And then actually among our traumatic brain injury patients, 88% of the patients that had a serious, severe, or critical injury severity score were actually retained at their community hospital despite the propensity to transfer most of those patients. So in agreement with the previous literature, we found that transferred patients were more likely to be minorities, underinsured, or transferred on a night or weekend. There's a number of factors that can communicate that maybe the staffing of the community hospitals, coverage limitations on nights or weekends, certain provider bias, whether implicit or explicit. The pattern of trauma injury may be an underlying factor, and certainly trauma protocols may influence the decision-making. So the non-clinical factors of race, payer source, and timing of presentation likely impact trauma and transfer decision making. And there's certainly an emphasis on avoiding under triage, and that may be facilitating or reinforcing these unnecessary transfers. And certainly optimal utilization of system and provider resources is critical for sustainability of trauma patients and trauma systems going forward. I thank you for the time and I'm happy to take any questions.
We'll open the floor for discussion.
Wendy Green, Emory University. Thank you for your presentation and your supporting the evidence regarding the ethnic diversity and the uninsured or underinsured and the challenges that they face and the lack of services that are provided when people get transferred out. I just wanted to posit in your direction that when you put your paper forward, that if you could use race ethnicity as part of the documentation, because race was created as a social construct. We actually, with our NIH scientists, when they did the genomic coding, identified that we have 99.9% of our genetic code is similar. And so it's unlike we have one human race, but we often use it incorrectly to use it as a social construct of race. So you just kind of have to keep that in mind when you're talking about race ethnicity.
Yes,
Thank you.
ma'am. I appreciate the feedback. Yes, sir.
I'm Eugene Shavley. I'm a surgeon in Campbellsville, Kentucky. We're rural hospital. I have two questions. Did it make a difference if a small hospital that was level 3 transferring to your facility, did they transfer less patients that were inappropriate? And the other question I have is, there's a trend that helicopters are picking up patients in the field and transferring them directly to a tertiary care center. Is this a good idea? Is this appropriate? And do you see a lot of inappropriate transfers directly from the field to the tertiary care center?
Yes, sir. Thank you. So as far as transfers from some of the community hospitals, we saw a high rate of what would be considered inappropriate or unnecessary, and sort of based in these non-clinical factors. And I think there's a tremendous gap in the coverage that these smaller hospitals have, particularly nights and weekends, and some of the specialties, patients that need orthopedics, neurosurgery, hand, facial injuries that unfortunately there's just nobody there to see them. And so they get transferred despite the fact that their injury pattern may not be that severe. We did not specifically look at transfer mode, but there's certainly evidence out there that helicopter transports are becoming more and more common, despite the fact that those patients are frequently discharged from the ED once they arrive or within 24 hours, and that mode is one costly and being overused.
Thank you so much.
Thank you.
Our next paper is Ratio of Economy of Motion, a new objective performance indicator to identify the correct surgeon during dual console robotic proctectomy, The presenter is Dr. Rosen from Emory University.
Thank you so much. I'm here presenting for Dr. Courtney Devon. She is our fellow. She was unable to be here today, so I will be here in her behalf. Thank you very much for the privilege to be able to present our work. These are our disclosures. So robotic surgery is pretty unique. You have a computer between the patient and the surgeon. And so we have a unique opportunity to record objective data. And there's an emerging field called surgical data science, which basically looks at objective performance indicators, or OPIs. These are metrics that are pulled from the video and pulled from the robotic data streams that can give us information about surgeon skill level, surgeon movements, operation flow, operation complexity, and even can help us predict postoperative outcomes. And here are some examples of OPIs, or objective performance indicators. For those of you familiar with the robotic surgeon console, it's wrist movements, finger movements, pedal use, and then there are the movements at the patient bedside of the robotic arms: speed, path, velocity, jerk. And then there are other OPIs that we measure, that we take a couple of different measurements and we combine them to describe economy of motion or smoothness or bimanual gestures. And so here's what we do. We basically, from Intuitive, who are our partners, we have this black box that we put between the surgeon and the patient side cart, and we can record data going back and forth between the two. We're a training center, we're Emory, and so we have lots of fellows and residents. And so you think about it, you have dual console surgery going on. So how do we know who's operating if we're trying to pull these objective performance indicators? Who do we assign them to at this part of the operation? Is it the fellow working or is it the attending working? And so this is a real limitation. So there's nothing out there to help you assign consoles. So we created ratio of economy of motion. And if you look at the equation at the bottom, essentially economy of motion is all the movements at the surgeon, the left and right arm movements, divided by all of the movements of the arms of the robot at the patient. So we basically said, we're going to take the economy of motion of console 1 and divide it by the economy of motion of console 2 and create a ratio. And we think this will help assign consoles accurately. So we recorded 21 robotic proctectomies, and the videos have no identifiers of the surgeon. There's no audio and there's no visual way to identify who's at which console, but the consoles have unique identifiers. The videos are timestamped using an annotation card. We created an annotation card for robotic proctectomy, and I'll show you what that looks like. And then we basically record OPIs, and we use machine learning to gather data and then interpret the data. Here's what our proctectomy card looks like. I know it's all read out. That's because we've submitted it for publication. But essentially, a proctectomy, we've broken down into 21 steps. So IMA dissection is a step. Of those 21 steps, a surgeon may do a task or a step once, or they may revisit it multiple times, or they may never do a task. So you may do lateral to medial, but you may not do medial to lateral, for example. And so we basically wanted to take those 21 operations and assign tasks and see if we could accurately assign consoles. So we did it two ways. One was we used our equation, ratio of economy of motion, which was instantaneous. It was either greater than 1 or less than 1, so it was either console 1 or 2. Or we did it the old-fashioned way. My fellow and I sat down and reviewed the 21 videos. We basically watched videos for a short period of time, a short number of tasks, and we said, that looks like the fellow working. That looks like the attending working. And then we extrapolated all the other tasks. I'll show you how we did that. So here's the video review. If you look at this table, the asterisks show of the 25 steps that we show here, we watched 7. And then we said, that's the attending working or that's the fellow working. And that was either console 1 or console 2. And so from that, all the rest of the console 1s and 2s were then back assigned to either the trainee or the fellow. During 21 cases, there were 1,800 tasks. So an average about 86 tasks per operation. We watched about 6.5 tasks per operation for 30 seconds. So we audited about 8% of the operation and then assigned the other 92% based on those audits. It took us 2.5 hours to do that. This was done by hitting a button on our computer. We measured the ratio of economy of motion, and then we assigned the tasks. And you can see all the way to the right that the consoles are assigned based on the equation. When we compared outcomes using ratio of economy of motion, if we assume that's ground truth, we had 91% agreement. You can see the first row, there's disagreement. Otherwise, the two columns show how we assigned it one way, how we assigned it the other way, and they all are in agreement except for one row. If we actually pulled out any of the rows of data that had incomplete data, we had essentially 100% agreement. And so in conclusion, there is a new field of study called surgical data science. Our group is studying this in the colorectal field, and we are focusing on trainee and surgical education. We have developed and validated a new metric, ratio of economy of motion, that will automatically and accurately assign surgeon consoles during dual console surgery. This is accurate, it's efficient, it's scalable, it's agnostic, meaning you can use it in any specialty, and we think it'll be very helpful for those who are investigating OPIs in the field of surgical data science. Thank you very much.
We'll take questions from the floor. While they're coming up, I have one. So I guess not understanding completely how this is done does this also work if you have two surgeons where the economy of motion is fairly similar, like a fellow close to the end of training and a new faculty member? Does it still work?
Yeah, so thank you very much. This is a great question. So this is work that we're doing over years and years, and we have literally about 40 different projects going on right now. And one of them is to compare expert movements versus novice movements. When we look at the data, we can clearly see the difference between people who've done 500 cases and 50 cases. We have a lot more difficulty discriminating somebody who's done 50 versus 80. One of the projects we're working on is looking at our fellows in the first quarter of their fellowship versus the last quarter to see how much ownership they take of tasks and how their movements are different. So the answer is no, we're not good at that yet, but it's one of the things we're investigating.
Seth, great presentation. I was a judge at the Sharks yesterday, and I think a paper from your institution demonstrated that the robot has the ability to establish or convert electrical current to newtons. So my question to you is, does the robot have the fidelity to establish which console is making the arms move, either organically or if someone signs into one console?
Thank you for the question. Yes, it does. So you can know whether console 1 is working or console 2 is working. And for those of you who work robotically, you can also move arrows on the screen, right? So you can be moving your arms at the surgeon console, but nothing's happening at the patient cart because you're disengaged from the actual patient cart. So yes, the robot, when we record the data, we know which console's working at any period of time. And we have just literally, when we look at our data, we have about 200 columns of data that we are pulling, different metrics, and we can look at speed, acceleration, jerk, idle time, clutching, finger clutching, foot clutching, camera movements. We're able to record anything for any task from either console, and we can separate. And now we have this tool to help us assign consoles. I hope that answered your question.
All right, final, very concise question and answer, please.
This was excellent work. I really enjoyed it. As you know, with trainees, we always have medical and legal implications of training them. Is any of this data available to your patients, and how do you let your patients know how much of the case the fellow is actually doing? Thank you.
So thank you very much. So at this point, we're not doing anything different than you otherwise do with any other surgery as far as informed consent with trainees. But actually, one of the areas of interest for us is if we can show what an expert movement looks like versus a novice movement, and if we can show that has clinical significance, so two big ifs that we hope to work on over the next few years, perhaps we can offer information to credentialing bodies, for example. These are metrics that you should meet to have robotic privileges and to maintain robotic privileges. Thank you so much.
All right, thank you very much.
Our last presentation is the American Association for the Surgery of Trauma Organ Injury Scale is associated with cystoscopic and percutaneous urologic procedures in renal injuries. Dr. William Burgode will be presenting from John H. Stroger Hospital of Cook County.
Thank you for the privilege of the podium. My name is William Burgode. I'm a trauma surgeon, and I'm presenting on behalf of the Cook County Department of Trauma and Burn in Chicago. I'm presenting our validation of the AAST grading scale for the kidney and its ability to predict adjunct surgical management. I have no disclosures. As a background, in 1989, the AAST created the OIS for the kidney. The scale goes from 1 to 5, with low-grade injuries being small subcapsular hematomas and perirenal hematomas, whereas more severe vascular injuries increase the severity grade all the way up to grade 5. I want to highlight that grade 4 injuries include those that extend to the urinary collecting system, and I'll explain the significance of this later. One of the best validating articles of the OAS was from Tinkoff et al. In the Journal of American College of Surgeons in 2008. Their national trauma database cohort included nearly 10,000 patients, predominantly blunt in mechanism, but analyzed collectively. They showed the scale had grade for grade associations with key outcomes such as mortality and need for operations. Other smaller studies also validate the score to predict things like nephrectomy, rhinorrhaphy, and the need for dialysis. We performed a trauma and quality improvement program review from 2017 to 2019, converting the abbreviated injury scores to AAST-OIS grades. ICD procedure codes were converted to key interventions. In particular, we sought out those for endourologic procedures, those being things such as stenting mediated via cystoscopy, and then percutaneous procedures such as percutaneous drains and then nephrostomy tubes. Our overall cohort included nearly over 26,000 patients. They were predominantly male in gender, predominantly blunt in etiology, and patients were quite significantly injured with a median ISS of 21. For the next 3 slides, the brackets at the top of each graph show statistically significant changes in consecutive grades and are specific to the mechanism of trauma, with blunt injuries in blue and penetrating injuries in red. Asterisks, on the contrary, denote differences between blunt and penetrating trauma within each noted grade. As you can see on the left, renal operation rates increase at each grade for both blunt and penetrating trauma, showing the scale's ability to predict surgical interventions. On the right, we showed a similar trend with slightly lower fidelity in grades 1 and 2 due to the rarity of nephrectomy in these grades. We analyzed angioembolization as a procedure to achieve hemorrhage control, and we saw the fidelity of the score, but with 2 different trends in the mechanism of trauma. Angioembolization in the blunt blue group increases with each grade of trauma, whereas in penetrating trauma, angioembolization increases up to grades 4, but then decreases in grade 5. In addition, the rates deviate significantly in grades 4 and 5 between the 2 grades. This is the key slide that I'd like to highlight that's fairly novel. Our analysis of endourologic procedures shown on the left, we showed the same trend in both penetrating and blunt trauma, with an increase up to grade 4, followed by a decrease in grade 5 trauma. There's a similar pattern in the percutaneous procedures as shown on the right, but this is not statistically significant, which is likely due to the infrequency of these procedures. Also of note, there are more differences between penetrating and blunt trauma within the lower grade injuries. In conclusion, the grading scale is valid for both blunt and penetrating trauma, although the scale cannot be equally applied to this depending on the etiology of trauma. Our novel finding that was not found in prior literature is that endourologic and percutaneous procedures were associated with AAST grade. These appear most frequently in grade 4, which, as I highlighted earlier, is defined by renal pelvic injuries and high rates of urinary leakage. We feel like this validates the most recent change of the AAST system from approximately 5 years ago. Thank you, and I'm happy to take any questions.
We'll open the floor for discussion for any questions. While we're waiting, a question for you is, again, in looking at these patients, do you think there was any way to differentiate between those patients who received a nephrectomy for, along with other injuries that were happening at the same time, that could have potentially been managed in a different form?
Yes, those associations were not as strong. So this was the total cohort. So these include patients with renal injuries and any other injury. I analyzed this, not shown here and not in the manuscript, in a couple of ways where one, it was just isolated injuries. There were still similar patterns and a difference between blunt and penetrating trauma. However, the associations were not as strong, meaning instead of having an association between 2 and 3, 3 and 4, 4 and 5, some of those associations were only between, say, grade 3 and 4, or only grade 2 and 3.
With no more discussions or questions, I thank you for your presentation, and this concludes our session, and appreciate everyone's assistance and participation.
Thank you.